Alright, I'm going to be recording now the ears, nose, and throat disorders. I have posted fast fact sheets on the asthma and the cystic fibrosis. Please read over those. And if you have any questions or concerns, please let me know. Thank you. Alright, we're going to be doing the ears, nose, and throat disorders. So if you don't have your PEDS book, please get it ready. Also, I have posted the PowerPoint to go along with this lecture. So if you don't have it, you may want to pause and get it copied before you get started. Alright, we're going to be talking about infectious conjunctiva first. And there are several types. And really it depends upon the cause on how you're going to treat that. It can be bacteria, which is common, but it can also be viral. It can be caused by plugged lacrimal ducts. It can be allergic type, and it's often called the pink eye. So there are several different types of infectious conjunctivitis. Bacterial is common. You'll see edema of the eyelid, reddened conjunctiva, enlarged nodes, discharge causing matting and difficulty wakening, especially in the morning. Their eyes will be matted. Older children may complain of itching and burning and feeling scraping, feel like it's scratching under their eyelids. This is highly contagious, especially hand-eye contact. Now, if it's plugged ducts, because the lacrimal ducts, treatment is actually just massaging the tear ducts every 4 hours when the infant is awake, and then after 1 year of age, they will open them surgically. All right, let me get back here. And this is covered on page, it's not in this chapter, it is on page 432 in your book. And I've got to go back and pick it up because it is so common. As far as the other types, you'll see viral. Again, it can be bilateral, can be unilateral, but usually it's bilateral. The adenovirus is the most common cause of that spreads from the hands to the eye contact. Allergic type causes intense itching, redness of the eyes with watery discharge, and a cobblestone appearance of the eyes. They get all huge and bulky. Alright, as far as looking at signs and symptoms, if you will look in your book on page 432, there is clinical manifestation of conjunctivitis, bacterial, viral, allergic, versus that caused by foreign body. Again, most commonly the bacterial known as pink eye. The purulent drainage, the crusting of the eyelids, the inflamed conjunctiva, and the swollen eyelids, and the trouble unmatting that eye in the morning. So you may want to remember those. All right, treatment is going to be antibiotic eye medication. We have Cipro eye drops now that is common. There's ointments. Viral, if it's viral, it's just going to be comfort measures, unless it's by the herpes simplex virus, and then acyclovir. Allergens, then we're going to give a systematic or topical antihistamines, steroids, decongestant, and mast cell stabilizers for that. As far as looking at the nursing care, we're going to do an assessment of the eyes, teaching the importance of hand washing, not rubbing their eyes, teaching about, or you're going to be using therapeutic management such as distraction if they start rubbing their eyes and other things to try to keep them from doing that. Prompt treatment is very important. Available, you want to avoid the use of contact lens during infections, of course, and then the way to instill eye drops. Upon awakening, you want to teach them to put warm, moist compresses to their eyes to help remove that crust, and then give their medication after that has been cleaned thoroughly. Just some fast facts, 90% of American children have had at least one ear infection before the age of 7 when we're talking about otitis media. And otitis media is covered, and I'm going back to my other chapter, sorry, on page 717. Incidence is the highest in children 6 months to 2 years, with a peak in the first 2 years of life. Now, it rarely occurs in children greater than 7 years old. Why is that? Well, because as children grow, the eustachian tube changes as well. Uh, Winter months cause more changes, so therefore they can get more respiratory infections, and that's why it's more common in the winter months, because they get more upper respiratory infections, therefore they have more potential of causing the ear problems, backing up into the eardrum. Now, what did we talk about might precipitate otitis media? Upper respiratory infection during this month, RSV. So a lot of times when a child has RSV, they also have otitis media. Risk factors, children who live in households with many members, children in daycare, and those who are around smokers. Passive smoke is thought to damage the mucosa of the nasal pharynx and eustachian tubes, thus increasing the susceptibility to bacterial and viral invasions. So why do breastfed infants tend to have a lower incidence of otitis media as compared to formula fed? Well, two reasons. Positioning, of course, is a big thing because a lot of people that feed their child bottles end up laying them down, propping bottles. So positioning is a big one. And then the presence of IgA. If you remember, IgA is Andrea, who lives in the breast milk, who helps prevent against viral infections in the breast milk. So remember that lecture. All right, external otitis or otitis externa. This is external otitis that involves inflammation or infection of the epithelium of the ear, the auricle, and the canal. It is more common in the summer, and it's often caused by swimming in contaminating water, resulting in swimmer's ear. It can also be caused by trauma by picking at the ear. Etiology, the external otitis can be caused by infections, dermatitis, or both, bacterial or fungi. Bacteria, the most common thing we get is Pseudomonas, E. coli, and Staph aureus. For the most common fungus that we'll see, we can get Candidus, and that one is the most common. And Aspergillus is also common. Clinical manifestations. Well, pain is the biggie, especially noted on movement of the auricle or application of pressure on the tragus. Drainage can range from serosangueous to purulent. Temperature, they're going to have elevations in their temperature, and swelling of the ear canal. Sometimes it even is to the point that it blocks hearing and actually causes dizziness and fainting. Now, if the drainage is a result of an infection caused by Pseudomonas organism, then the drainage will be green and have a musty odor. Diagnosis is made by observation with an otoscope light and a large speculum in the ear that it will accommodate, and you want to do a culture and sensitivity on that drainage if you're not sure and it's not clearing up with antibiotic therapy. Therapeutic management, Tylenol or codeine. If it's just mild, then we'll give them mild pain, then we'll give them some Tylenol. If it's severe pain they're complaining, they may give them some Tylenol with codeine or Tylenol 3. Antibiotic ear drops, the newest one's Cipro, and we'll be using that one quite often. Topical antibiotics like neomycin. Nystatin for fungal infections. Sorry about that, my phone's going off and I thought I had it turned off. If the surrounding tissue is involved, systemic antibiotics are prescribed. Improvement should occur in 48 hours. Now, that's a good thing and that's a bad thing. Because it improves in 48 hours, the child's better, she's doing better, he or she. But because they're doing better, the parents don't tend to want to give those antibiotics for a full 7 to 10 days as prescribed. As far as nursing considerations, careful hand washing and disposal of materials that are saturated with drainage, of course, be careful with that. Drops should be administered at room temperature. The tip of the dropper should not touch the auricle during administration, and the ear is positioned so that the drops run down the canal. And you want to wait about 2 minutes. Have them lay there in that position before they get up and move. You may want to remember those. Now, what about disorders of the middle ear and the mastoid? Well, we've got otitis media, known as OM, acute otitis media, known as AOM, and otitis media with effusion, known as OME. Chronic otitis media with effusion can also be present. And it talks about these on your book on page 718. The most common problem of middle ear is acute otitis media. Of all of these, the middle ear acute otitis media. And I call this the painful earful. Usually it's a childhood disease associated with colds and sore throats and blockage of the eustachian tubes. When we talk about just the term otitis media itself, that's just a general term, and all that means is inflammation of the middle ear. Acute otitis media, on the other hand, and these definitions are these are on page 718. And you see there that acute otitis media is the acute onset of ear pain marked by redness of the tympanic membrane. So with acute otitis media, you have redness of the membrane, and you may or may not be able to see the structures. Otitis media with effusion. Fluid is in the middle ear without inflammation. Fluid is in the middle ear without inflammation. Chronic otitis media with effusion lasts more than 3 months. Means it lasts more than 3 months. Acute otitis media is often caused by Streptococcus pneumoniae, Haemophilus influenza, and Staphylococcus aureus. It's not known what causes the non-infectious type, but it's often associated with blocked eustachian tubes secondary to the edema of allergic rhinitis and enlarged adenoids. The incidence is highest in children aged 6 months to 2 years. Then it gradually decreases with age, except for a small increase in the incidence when the child enters school. About 75% of all children seen by a pediatrician has had one episode of otitis media by at least 2 years of age. Again, it's very uncommon once the children reach over age 7. Acute otitis media, then, if I'm looking in the ear, compared to otitis media with effusion, I have the otoscope. If it's acute, I'm going to see an intact membrane that appears bright red and bulging. Probably won't see those bony landmarks that you looked for or the light reflex. If it's acute otitis media with effusion, then it's going to be slightly inflamed, usually a duller gray membrane. Maybe some obscured landmarks may or may not be able to see them, and you will actually be able to see a visible fluid level behind the eardrum. Clinical manifestations for acute otitis media is earache, fever, and purulent drainage may or may not be present. Now, otitis media with effusion, they will complain of fullness and pressure in the ear or popping all the time. Clinical manifestations in the infant and the young child is crying, irritability, rubbing, pulling at that ear, constantly moving their head back and forth, difficult to comfort, and loss of appetite can also occur. Now, in the older child, crying and or verbalized feelings of discomfort. The older you get, the more they're going to tell you, my ear hurts. Irritability and loss of appetite, again, along with maybe some lethargy. Chronic otitis media can result in hearing loss, difficulty communicating, feeling of fullness, vertigo may or may not be present, ringing in the ears. Therapeutic management. Well, some do absolutely nothing. They do the watch and wait method. Others have analgesics, antipyretic drugs that they try. Some try the surgical method, such as a TNA, PE tubes, where they go in and actually make an incision in the eardrum, and they put a tubes in your ear to allow for that drainage. Some treat with antibiotics, 5 to 10 days. If they have had more than 3 ear infections in the past year, if they have a positive respiratory culture, or they are a high-risk patient. And some physicians, it's not on here, treat with antibiotics no matter what. Now, of all of these choices, the American Academy of Pediatrics supports we do nothing. We do the watch and wait method. Wait 72 hours, see if they do better. And if they don't, if they're a healthy infant otherwise, greater than 6 months, then we can put them on something. Amoxicillin is the drug of choice. And prevention, one of the things we can do to give prevention for this is that immunization called Prevnar. If you don't remember about Prevnar, you may want to go back and look it up. So, drug of choice is ampicillin or amoxicillin. Zithromax increases compliance because you don't have to give it as often. Augmentin's a backup. Sulfonamides, Bactrim, cephalosporins, and then Rocephin in a single dose. Even though they have done studies and shown that amoxicillin still continues to be the best drug of choice. So, why is follow-up evaluation so important after antibody therapy? Well, to evaluate the effectiveness of treatment and to identify potential complication as in infusion or hearing impairments. Because these children don't hear right, and if they don't hear and it's not clearing up and they didn't take the medicine and they keep getting these repeated infections, it could actually mess with their speech later on as well. So what about PE tubes? Well, they insert these under general anesthesia, and what they do is actually facilitate drainage of that fluid from that middle ear. And it actually are called PE tubes, are called pressure equalization tubes. And some children actually even benefit from a TNA, a tonsillectomy and adenectomy, if the PE tubes do not work. They usually remain in place for about 6 to 12 months before they are spontaneously rejected. You want to make sure you're describing that to the parents, though, that they maybe have some bloody drainage when those come out, because it may scare them. Sometimes they don't even know when they have fallen out. They do have some newer tubes on the market that they can actually now get into the water and swim, but no diving. They may need to be replaced. It's not a cure. And be careful, again, about getting in the water unless it is the new kind that you can, but all of them, no diving. Nursing considerations, interventions for pain management, again, Tylenol, interventions for ibuprofen, interventions for potential impaired skin integrity, depending upon if they have any drainage, interventions for someone who has the ventilation tubes, facilitating drainage, preventing complications, and teaching and always being there for emotional support. As you can see, it's not without complications. They can have some conductive hearing loss to intracranial infections if they do not take care of this. So, teaching regarding prevention of otitis media, what would you teach the family? Well, protect the ear canal, right? Don't go swimming in contaminated waters, okay? Get adequate and early treatment for upper respiratory infections. Never insert objects into the ear canal, particularly to remove wax. Do not insert objects. Feed the child in an upright positioning. So there are several things that we can do to help teach the family. Alternative therapies, there are some other therapies out there that people are using. There's anything from chiropractic therapy to massage therapy to some of your boosters for the immune system, your echinacea, your garlic, your golden seal. So there's other things that people are trying as well. They have had some luck with these. According to individual, you can read where several of these have been successful. Other remedies, I've heard of people doing all kinds of things that are unsafe, but I've also heard of other things, peeing and pouring it in their ear a little bit helps because of the acidity and stuff. Now, I wouldn't suggest that, but there are some few old-timers out there that did do those kinds of things. All right, that's the end of the painful earful. If you got any questions, please let me know. Rhinitis. I want you to review this on your own, but I am going to hit 4 high points only. 4 high points on rhinitis. Number 1, it's caused by inflammation of the mucous membrane of the nose. Number 1, caused by inflammation of the mucous membrane of the nose. Number 2, you need to avoid allergens and irritants. You need to avoid allergens and irritants. You need to avoid allergens and irritants. Number 3, proper use of medications. Make sure they know the proper use of medications, particularly inhalers or something like a Rhinocort inhaler. And number 4, for best results, make sure the nasal passages are clean before you use nasal medications. So if they have to put something up their nose, some kind of nasal spray or something, they want to make sure they blow their nose carefully and that it's good and clean before they start, so the medicine works like we want it to. Foreign body in the nose. Children particularly are apt to put an object up the nose. And here's what you watch for: unilateral, purulent drainage, and foul odor. You're around your little kid and it's just, what's that smell? What's that smell? Ooh, that drainage from your nose. They probably stuck something up, but they shouldn't. And we have found anything from batteries, and if they are up there, you got to remove them very carefully, because you can cause tissue damage when you're taking them out if you break the casing. Rocks, beans, M&Ms, about anything that you can imagine the child will find will stick up their nose. Sinusitis. The location of pain with sinusitis is important. Of course, if it's in the maxillary area, then they're going to hurt under their eyes, the front of their face, and the dental area. If it's a frontal sinusitis, then they're going to hurt over their eyebrows. Ethmoid, the periorbital and frontal area. And splenoid, behind the eyes and at the back and base of the skull. Medical management of sinusitis is aimed at pain relief and control of infection. Tylenol to broad-spectrum antibiotics to nasal decongestion. Nasal washings with neti pots. If you've not seen that, please get on the YouTube and look at a neti pot cleansing. Pretty interesting. Surgical interventions may also be necessary. Now, Tylenol is usually advised since aspirin is associated with nasal polyps. Sinus surgery, drainage and irrigation. Irrigation surgical procedure can be performed in a physician's office or a clinic. The area is anesthetized and a large gauge needle is inserted under the inferior turbinate of the nose and into the affected maxillary sinus. Fluid or pus is withdrawn, and if no purulent material is present, the sinus is irrigated with normal saline. So that is not an easy task if you think about it, going in and having just some drainage and irrigation to the sinuses. There's the Caldwell procedure, that's the clearing out of the maxillary sinuses through the incision through the upper lip as well. And then you actually can have an ethmoidectomy where you have a drainage of the ethmoid or the splenal sinuses. Preoperative teaching for sinus surgery, you want to always assess the level of knowledge. They're going to be NPO 6 to 8 hours prior. They're going to be on sedative medications. You need to let them know they're going to feel pressure, not pain, even though a lot of people have told me they feel pain. Nasal packing for 24 to 48 hours post-operatively, and they will have a mustache dressing. You want to let them know that. They may have a lot of bruising, look like what we call raccoon eyes for a while because of all the swelling around their eyes and nose area. Post-operatively, you want to position them on their side. Make sure that they are spitting out any kind of extra secretions. In a mid-Fowler's position. Ice for the swelling. Monitoring for any type of complications. They'll need good mouth care. And then changing that nasal pad as needed. Also, you want to encourage fluid intake. Sorry. And you want to teach the patient to avoid blowing their nose for 48 hours after the packing is removed. Now, they say sneezing too, but if you're like me, if you got to sneeze, you got to sneeze. Report signs of infection, and they will have some tarry stools because they are swallowing some of that old blood. Avoid constipation. You don't want them straining, and take all their medications as prescribed. Prevention, avoiding factors that contribute to sinusitis. Of course, preparing environmentally controlled, rooms. And it says bedroom particularly, but any room, carpets and things like that. Get plenty of rest and fluids. Take medications as prescribed until they're all gone. And maintain a constant room temperature to keep that nose from drying out. Nosebleeds, epistaxis. This usually originates from the anterior septum, and it can be caused by several things. Anywhere from nose picking to forceful coughing and sneezing to fracture, foreign body, rhinitis, hypertension, or coagulation disorders. They did a study, and it's kind of scary. They did a study of 115 nurses, doctors, and paramedics, and some non-clinical staff from an ER department. And this was a major teaching hospital. PITAL, even though I can't spell it. Only one person in 3 could demonstrate the proper way to control, that's 33%, And this is 43, but really if it's 1 in 3, that's about 33%. And among the trained ones, only 43% got it right. This up here included the non-clinical, and with all the trained people, only 43%. So not even half the people know where to apply the pressure. If you feel of your nose right now, you'll feel it start at the top, at the bridge between your eyes, go down until you feel that cartilage starting to wiggle. And right below that is where you press. You don't want to press on the upper part because that is just pure bone. Conservative methods position the patient sitting with their head tilted forward. Apply direct pressure over the soft outer portion of the nose against the midline septum for 5 to 10 minutes. You can apply ice and cold compresses. They may actually have to go in and do a cauterization where they go in and actually stop the bleeding, or give some topical vasoconstrictors. Now, a nosebleed that's just confined to one side of the nose is almost always an anterior bleed. But a posterior bleed it can flow from one side, but usually a lot of times a posterior bleed will be both sides. Blunt trauma usually results in posterior nosebleed. So some kind of blunt trauma, they usually bleed from both sides of their nose, and that usually tells you that is a posterior nosebleed. The best thing I can tell you is remain calm, because with children, they see all that blood and they don't remain calm. If it is a posterior bleed, then we're going to do what's called a postnasal packing. A posterior bleed is less common, but when it does occur, it's more profuse and harder to manage and a lot more serious. They can do what's called a tampon nasal pack, and it looks just like a tampon. It's a dry, compressed sponge that resembles a tampon. It's got a little string attached. Once the pack is inserted, the blood or normal saline causes it to expand automatically. Balloon pack or balloon tamponade, where they put in a 14 French Foley catheter and inflate that until the bleeding quits. All right, disorders of the pharynx and the tonsils. Pharyngitis is an infection of the mucous membranes of the pharynx. This can occur usually when you've got acute rhinitis and sinusitis. You may get pharyngitis with it. 90% of all cases are caused by virus. And if it is bacterial, then it's usually group A beta hemolytic strep. So how do I know if it's a viral or a bacterial? And you need to know this for the exam. If it's a viral, you're probably going to see a low-grade fever. It's going to come on gradual. You're going to have usually no tonsillar exudate. May have a sore throat, but no rash. If it's bacterial, then you usually have a high fever with an abrupt onset. There will be erythema of the tonsils with white and yellow exudate present, and a possible rash, particularly a petechiae rash on the chest or abdomen, indicating the strep. Also, it's viral. Its associated symptoms include cough, rhinitis, hoarseness, and malaise. CBC count may be normal or slightly lower than 10,000, and they'll have a negative throat culture. With bacterial, it's going to have sudden onset of chills, malaise, and headache. White count's going to be elevated, and the throat culture will be positive, particularly for group A beta hemolytic strep. Now, there are two serious complications that can occur from this, and number one is rheumatic fever, and number two is acute glomerular nephritis, and we'll talk about that later when we talk about GU. Rheumatic fever, we've already been over, and acute glomerular nephritis. So what's the treatment? Well, if it's bacteria, it's antibiotics, and typically penicillin G or V, depending. Usually we'll give that over about 10 days. If it's viral, then it goes back to just doing supportive care. You want to do a lot of teaching, comfort measures. They need a lot of warm gargles, increasing their fluid intake to 2 to 3 liters per day. Especially if the symptoms reoccur. It is not contagious 24 hours after treatment is started. You need to remember that. 24 hours after you give them antibiotics, they're no longer considered contagious. Family members who develop a sore throat also need to be evaluated and possibly treated. All right, tonsillitis. This is an inflammation of the tonsils and the lymphatic tissue that are located on each side of the oral pharynx. The function of the tonsils and the adenoids, we know it serves as a part of the body's defense against infection. Serves as a part of the body's defense against infection. It affects 5 to 10-year-olds and most commonly. The acute form lasts 7 to 10 days and is most often caused by group A beta hemolytic strep. Viruses can also cause tonsillitis. All right, so what do we know as far as clinical manifestations? Well, we're going to grade those tonsils at a grade 4, and if you don't remember, those were called your kissing tonsils because they're touching. You will have mild to some moderate sore throat, difficulty swallowing, fever, swelling and tenderness of your lymph nodes, particularly in the submandibular area. Muscle and joint pain may also be present, along with chills, malaise, headache, and you just feel like something's in the back of your throat all the time. May or may not have some difficulty breathing, so you want to watch that. Clinical manifestations with chronic is recurrent sore throat, a lot of drainage again. Your tonsillars, particularly, are going to be swollen a lot, frequent attacks of acute tonsillitis that just keeps coming and coming and coming. If it's an acute, then rest, adequate fluids, again, Tylenol. Sore throat lozenges, warm salt water gargles, and antibiotics if it's a bacterial infection. Chronic, they may have to have TNA, a tonsillectomy and or adenoidectomy. Nursing considerations post-op, immediately post-op position on the abdomen or side. They need to be discouraged from coughing. You don't want to put any kind of extra pressure there. Analgesics and no red products. Now, I've had some physicians say that nurses should know the difference between a red popsicle coming up and blood. But a lot of policies at hospitals are still no red products. Post-operative complications, you can get hemorrhage, and you need to remember that the most common symptom that you're going to see is the child who's continuously swallowing, because that blood's continuously trickling down the bottom back of their throat. If you got to look, you better do it very carefully. Hemorrhage, it usually occurs 5 to 10 days post-operatively. So in the immediate post-op period, and then 5 to 10 days post-operatively. And why is that? Well, in 5 to 10 days, they're feeling better, so they think they can eat those Doritos or that pizza crust or whatever, and it's scabbing over back there, and it tears that scab loose and causes bleeding again. They can do some damage to some of the nerves, so you want to make sure that you always check the smell and taste to make sure they did not cause any damage once they come back. Croup syndromes. You need to know about croup syndromes. This affects the larynx, the trachea, and the bronchi. And now, if you look on page 721, there's a nice chart, and we'll be going over that chart. Now, croup is just a term that it's a broad classification, just means upper airway illness. So when you hear the word croup, it's an upper airway illness. And there are several different types of croup. Epiglottitis is the most serious. LTB is the most common. And acute bacterial tracheitis is also seen, and it can be serious. All right, so when we're talking about croup syndromes, let's see here in the book, if you'll look with me. Let's look at acute epiglottitis first. It affects 2 to 5 years old, but it varies. Main agent is bacteria. It comes on very quickly, and they're going to have major symptoms such as difficulty swallowing, stridor, aggravated when supine, drooling. Drooling's a big one. You have a kid who's coming in and they're just drooling and it's coming out of their mouth. They act like they don't want to swallow. That's a big one. High fever, toxic appearance, like they just don't feel good, in trouble. Rapid pulse and respiration. Treatment is airway protection, racemic epinephrine, corticosteroids. You get them on board quickly these days. Fluids, antibiotics, and reassurance. Now, there are 2 nursing alerts on page 721. The first one says 3 clinical observations that are predictive of epiglottitis include absence of spontaneous cough, presence of drooling, and agitation. So you need to remember those. It also talks about them being in the tripod position, and it talks about them sitting upright and leaning forward with their chin thrust out, their mouth open, and their trunk protruding. That's the tripod position. And the drooling of the saliva is common because they can't swallow it. They have so much difficulty because of the pain. The other nursing alert says throat inspection should be attempted only when immediate endotracheal intubation can be performed if needed. So you really only want to look in the throat if you have been trained to do so. If you do, you can, because looking in the throat can cause a partial obstruction to go to a complete obstruction and precipitate that by throwing them into bronchial spasms. So you need to avoid visualization of epiglottitis and let the skilled personnel do that. Establishing airway is priority with these patients. Humidification, getting that going. This is always considered a medical emergency. Always considered a medical emergency. All right, the next one that it talks about is acute laryngeal tracheal bronchitis, LTB. Now, LTB occurs in infants and children younger than 5, but usually it's viral in nature. Comes on more slowly, followed by upper respiratory infection. But you can see here it can get into some complications such as stridor, and we know that's never good. Hoarseness, dyspnea, irritability, fluids, and reassurance, and low-grade fever, Now, treatment is racemic epinephrine, corticosteroids, fluid, and reassurance. So we're still giving some of those same things to work on that inflammation and making sure that they are hydrated well. Of those signs and symptoms, hoarseness, brassy, cough, and stridor are 3 big things you're looking for. Now, with these children who have croup, of course, you're going to encourage the caregiver to stay at the bedside as much as possible because you want to keep that child's anxiety down as much as you can, and that will also help ease some of that respiratory effort. Okay, acute spasmodic laryngitis, which is the last one you have to know about. You don't have to know about the acute tracheitis. Acute spasmodic laryngitis is 1 to 3, viral, sudden at night. And this is the true croup that you think about. Related usually to an upper respiratory infection where they have that croupy cough that appears particularly at night, and they'll be fine during the day, and at night they'll get bad again. Usually this is self-limited. They may have hoarseness, stridor, dyspnea, restlessness, tendency to reoccur. Treatment is moist, something cool and moist, and reassurance as well. Cool is preferred to decrease that mucosal edema. Now, oral feedings, you have to be careful about because sometimes we have to feed them with IVs and stuff because that lessens their physical exertion. They are struggling so hard to breathe with some of these croup syndromes that oral feedings just makes it worse. So if they're struggling to do that, then we make sure that they're getting plenty of fluids in until they are able to take in other things. All right, that's the end. No more sections, you'll be glad to know. Thank you. If you have any questions or concerns, don't hesitate to let me know. Bye.